both of you will get into the conversation. So we're starting to have people roll in right now. I love that feeling. I see that Debbie's here, Inger's here. Nice to see you, Inger. I see Jen Atkinson is here. Folks are starting to stream in. So for those folks, as you're starting to stream in, Dr. Neal's here. Please, Dr. Paulie's here in the chat section, reply to all panelists and attendees, not just all panelists, because if you do, then only Dr. Lekovich and Lisa and myself will see you. So all panelists and attendees, I love this tradition that we've gotten into in webinars of people saying where they're from and just giving a hello to everyone else. It makes everything a lot more interactive and social, and I love the community aspect of that. So as you start to roll in, hey, Dr. Gladstein, as you start to roll in, please, hey, Connie, please introduce yourself in the chat by replying to all panelists and attendees. Hey, Dr. Paulie, thanks for kicking it off. So as everybody else streams in here, I'd like to introduce our guests and welcome to them. One I just met about 5 minutes ago, and the other one I've known for 5 years. So
we all, I should say.
Well, we're happy to have both of you. Dr. Jovana Lekovich is practicing at RMA of New York. She joined that group in 2017. She is a New York gal. She did her training at Cornell for both residency and fellowship. And Dr. Lekovich, you said your specialty is in the you have a special interest in fertility preservation?
Would be, yeah, exactly. I take care of a lot of the oncology patients or patients who need to fertility, in addition to just bread and butter in fertility service.
Well, thank you for representing both the REI community and the New York side of thing. Lisa Rinehart, I've known for longer than 5 minutes. And Lisa, when I was doing the webinar with Dr. Katz and Taylor and Jeff from Engaged MD, and I saw your name in the attendees, I thought, oh, shoot.
Sorry.
I should have probably had Lisa on as a panelist for this webinar. So we're taking care of that now. And the reason why I want to have Lisa as a panelist is because she's worn so many hats and does wear so many hats. In addition to having been a fertility nurse, she is an RN. She is also has the letters JD after her name. She is an attorney, so she's involved with the NPG group. That's the nurses group, the LPG group, that's the legal group within ARM, as well within ASRM, as well as ARM, which is the reproductive managers group. She has her own company called LegalCareConsulting, and a really unique perspective on as an attorney and as a nurse. And Ms. Rinehart, I am happy to have you on the program as well. Thanks for joining us.
Thanks, Griffin, and please call me Lisa. You scare me when you call me Ms. Rinehart.
Well, everyone that listens to the show knows that I like to start with the honorific, and then we get into first names as we let our callers down and be a little more comfortable. So maybe we can just give, we can start high level because we've had a number of questions in advance. For those of you popping on right now, if you would, in the Q&A, please drop those. You can drop your questions right into the Q&A. We've gotten a few in advance. But before we dig into those, maybe we can give just at a high level of, we've all been, for those of you that are experts, you've been experts for about 2 months in terms of COVID-19 and standard operating procedures. I guess, maybe give us a little bit of background on how you're deciding to make the standard operating procedures that you are or have recommended up to this point, and then we'll start dissecting what they are individually.
Okay. Did you want to?
Lisa, why do you go first?
You know what, I'm just going to kind of give you a little bit of an overview since I've been doing SOPs for quite a while, even many moons ago when I worked in the hospital. And it's, why do we write SOPs to begin with? And I think that's where, when you look at COVID, is where you have to start. You write them to give your staff patients, management, whatever, some direction. You write to make sure that you are in compliance with any laws or any professional standards that are out there. And then you write them to ensure patient safety, staff safety, and to do training. So I think all of us can see that with a brand new event that not only came in as a novel virus, but as totally changed the way we were living, the way we were working, and now how we're going to reopen, that we absolutely need to have some direction. So, you know, they're kind of scary when you call them SOPs, but when you just call them, let's give everybody direction, now we kind of know where we're going. And so what they are step-by-step processes that are going to help us understand how to perform a task and how to do it consistently, and hopefully how to do it well. Writing them, a lot of places have formats, but basically, you know, what is the specific piece or task you're doing? How to start an IV, for example. Who's going to do it? What equipment do you need, if anything? And then what's the process? What is the exact process that you want? I always add in there references, which I think sometimes we forget. All of us can come up with stuff on the fly, especially those of us that have been doing our jobs for a while. Oh yeah, fine, I can tell you how to do it. But if somebody wants to go back and check as to why you put that step in there, it's really very, very helpful to put references in. So I think moving forward, as we start to look at what SOPs do we need to look at why we're doing it, what we have to do, and then I venture to say you need a key person in your organization. And maybe Jovana, you can talk about that. Somebody who's going to be the go-to for helping direct how these SOPs are written, and who's also going to be able to help monitor them, because that's a big piece of this. Is we can write anything we want. If you put it on a shelf and nobody does it, it really doesn't help us. It doesn't give us the direction we need.
Sure. Yeah, I agree. I mean, I second everything, Lisa, that you just said. I think that we are one of the organizations that really, in everything that we do, whether that's, you know, how we handle a CMV positive donor sperm, or whether it's, you know, a deadly viral pandemic, we rely a lot on SOPs and on protocols, because once you reach the clinic or organization of this size and handling literally thousands of patients a year, you really have to rely on them to stay consistent and to provide the best quality care. And so obviously there are SOPs in place that we all as a group have been sort of in organized fashion have been writing and have been collecting all the data as physicians, and have been sort of determining on how to go in this situation. The problem is not having the guidelines. And so, you know, in the words of our governor from the other day with one of his interviews, I really also like the idea of, you know, going stone to stone across the morass, which also is an important thing to remember, that going into an untapped situation that nobody really knows how to handle, obviously having a plan, safety first for both patients and employees, following the guidelines, following the guidance from medical societies, as well as, you know, politically and from the government, and also every step of the way being sort of formed, and you might not know the whole path, but firm stone after firm stone, and just having sort of all of these things in mind, being inventive when certain situations also appear. You cannot put everything in the SOP. But I absolutely agree with you. And, you know, in order to ensure that the organization or the, you know, the sort of the centralization of how we are organized and how we make sure that these measures have been followed by everyone, it really trickles down through the, you know, the VP of operations, through our medical director, through our CEO, and through all the physicians really, and through different managers of different services within our organization, which is the nursing manager, the IVF coordinator manager, the finance department managers. And so we're all, just as long as we're all on the same page, I think it's important having those plans in place.
So Lisa, how much of it is, I mean, of what's new, how much of it is brand new standard operating procedures versus addendums to existing SOPs?
I think, you bring up what you've got already, and I think that's always a good starting point. Most of us have had what we call disaster plans. So that gives you some place to start when you feel that your entire operation has been blown up and you have to start over again. We've also taken care of patients with infectious disease. That is not something that's new to anybody who's been trained in medicine. And so you can take some of the procedures that you already have and adapt them. What's going to be a little bit different, I think, is the extreme of it, because COVID is turning out to be something that is much more easily spread than we realized. It's a much more fluid situation. So you're going to have to adapt some of your policies and procedures to encompass social distancing. We've taken care of infectious patients before, but we never said you had to be 6 feet apart from their partner or from your staff, the person you're
Or that their partner can't come to the office.
Exactly. I mean, that's been very.
I remember, and I'm interrupting you, Lisa, but you made me think of how quickly this has all moved. I remember, I think it was March 13th, talking with my sister and saying, yeah, we're thinking about not letting our clients, we're talking with our clients about not letting partners come into the office. And my sister's in ours, she said, no. and lo and behold, and now every single one of our clients has asked partners to stay home. So please continue. Your point was that we've dealt with infectious diseases before, but some of these considerations we hadn't even dreamt of.
We didn't, because before it would be you would isolate the person and whoever was going to take care of them would protect themselves, go take care of them and come back. And you could still go have coffee with, your colleague. You could still go take care of other patients. That's not the same. And so I think where you can use some of your policies and procedures as a basis, we're going to have to be a little bit more creative on other areas, which is kind of fun for me. I love going through workplaces and just saying, how else can we do this? How can we sit 6 or 8 feet apart and still let people do their jobs? Can we let our staff work from home? Can we job share? What are we going to do about team staffing, which I'm sure comes up? I think it actually, makes you think outside, and I hate the term outside the box, but it is outside the box. The other thing I will mention, though, is the organizations that have really been studying this longer than maybe some of us have put together some unbelievable frameworks for us to use. The CDC has a lot of information that makes it much easier to adapt your policies and procedures or write new ones with regard to the coronavirus. And so I say to you, go to the CDC, go to the WHO websites, go to ACOG. It'll make your job a whole lot easier.
I wanted to ask you about that, Jovana, because you mentioned that a problem is either having or not having guidelines, and how we use guidelines to inform the standard operating procedures. Lisa mentioned the CDC. RMA of New York is a pretty large practice. It's in a large market, and we do have physicians from large practices in large markets on. We also have physicians from very small practices in small markets on that might not be affiliated with a Mount Sinai. So in addition to ASRM and others, the Fertility Providers Alliance, and as Lisa mentioned, CDC, where are you mentioned the importance of guidelines. Whose guidelines should people look to draw from the most?
I mean, I can tell you how it went between, different IVF centers. Some of us are affiliated with hospitals, and so naturally would follow or would adopt some of these policies because they've been written already, and you don't need to reinvent the wheel. You can adapt it, as Lisa said. A lot of it was really sharing information between different centers, collegial sort of discussion of what this center is doing, why are they following that guideline, and and then really trying to try to make it work in your environment, because not every waiting room is the same. Not every patient population will be the same, and you might not have to deal with certain things as, you know, some other centers might have to deal with, which would be, let's say, you know, having 150 patients in the morning during monitoring hours. Not every center needs to deal with that difficulty, and so how do you overcome that, and how do you think inventively to, you know, still provide care with volume and not, you know, while following the guidelines. So, you know, I know that, you know, talking to some of my colleagues who are affiliated with Cornell, obviously following local guidelines from the hospitals and applying them into their setting. We applied a lot of the things from the Sinai hospital guidelines. CDC is a great resource. I would say WHO, and then really just sharing information, being a united front. All of us are in this together. And I always said that, you know, 14 or 15 or 100 heads are smarter than one. So if we're driven by the same goal, which is to resume and to be able to safely provide care to our patients, I think it's very inventive and advanced to think all together as well. So we've been sharing information with other centers as well.
And maybe some of that information we'll be able to share with the audience today. We've had a few specific questions. And again, if you have questions, drop them into the Q&A. The Q&A button is different from the chat button. These are a few questions that we got from registrants ahead of time. And maybe I'll direct this one to you, Lisa, since it is about liability. Normally when I give the disclaimer, I always say, I am not an attorney, you are, but I think we give the famous disclaimer that this isn't particular counsel, this is not particular legal advice, but rather insights. And the question is the practice liable if a patient without symptoms infects an employee? So I'm guessing this means, you know, they've perhaps they've screened for symptoms is what they're asking, and then an employee is infected by an asymptomatic person that passed through their symptom screening. Can the practice be liable if their employee is infected?
You know, this isn't the first time that I've heard this question, and I'm sure we're all thinking that. What if it isn't just our employee who gets infected? What if it's one of our patients who gets infected? So have it go the other way. And again, I can only give general advice. I'm only licensed in one state, but I can tell you first and foremost, you can be sued for just about anything. So that's the first answer, okay? You have a willing plaintiff, there will be a lawsuit. In this particular—
Whether there's a willing plaintiff, there's a willing lawyer.
You got it. And I don't condone it. I don't do malpractice at all. But I will say it's going to be one of the things you have to prove is that somewhere there was negligence. Because that's probably going to be the main claim, is that somebody was negligent along the way, which fits in with why you need to have some, you know, SOPs that people are trained in and are following. But then they also have to prove that you are the ones that actually caused the injury. In this particular arena with this novel coronavirus, it is going to be very, very difficult to prove that a person got the coronavirus from, you know, Denise the nurse. How are you possibly going to do that if they're out and about in any type of society? You would have had to have them completely isolated from anybody else but Denise the nurse. So that's where I think a lot of these are going to fall down. And again, you know, yes, there will be creative lawsuits, but do I really think that a practice, if they're following good safety measures and following their own SOPs, are they going to be held liable? I think it's going to be a really difficult case. I just don't, you know, I can't say never because stranger lawsuits have happened. I just don't see how it would actually even get through the entire court system. It'd be very difficult to prove.
The next might be a question that falls in both of your wheelhouses, which is which actions do you take when a staff member or a patient or any visitor encounters symptoms after they've visited your clinic. So maybe you get a phone call from the next day, a staff member or a patient, and I was there 3 days ago, or I was there 5 days ago, whatever it might be, and I've tested positive. What happens then?
Jovana, you want to say what would happen in your center, since I know you have SOPs?
The plan in place in that situation is to basically, we haven't been doing any testing yet until their validity is proven. And so we've been referring the patients with, let's say, she's calling with symptoms, then the plan will be to refer her to either urgent care or her primary care physician to get tested. If she's calling and being positive, given that we're just slowly starting to go back after being closed for almost 6 weeks, is starting to go back and treating patients. The first and foremost, we cannot treat patients. Our patients know that once they're starting any of the treatment cycles, whether that be ovulation induction or IVF or frozen embryo transfer cycle, their cycle will have to be discontinued as again, as per the guidelines of ASRM, obviously. And so the patients would be again referred. We did not want to mention in our SOPs or to adopt or hijack any of the care for the patient in that scenario. So the patient would have to obviously follow up with a doctor, either infectious disease physician or a primary care physician who would treat their condition. What we have been doing with primary and secondary and tertiary contacts, I think it depends on when you're asking me this question. If this is, March 7th, and this would have happened, we would have obviously quarantined them as per DOH recommendations for primary, secondary, tertiary contacts. But, nowadays, if you ask me that, somebody who got into contact with a patient that has been positive, you might go into a liquor store and get the infection, or might just be walking the sidewalk from your building to the car or something in New York City and not really being able to every one of us, is what I'm trying to say, has been in at least secondary or tertiary, if not the primary contact with somebody who's been infected. So nowadays, again, it's a situation that obviously requires a discussion, but that's how we would be dealing with it. We have to be identified everybody who's been in contact with patient, and then sort of either quarantine them or monitor for symptoms or test them.
You can't add anything to that, Lisa?
You know what, I just would add, and I totally agree with that approach, and I think most departments of public health are, saying that, but I think it also depends on the extent of the contact. If this was just a very superficial contact, she came in, had blood drawn, the person had, who drew the blood had PPE, she goes home and 3 days later you hear, chances are that there was not a lot of time spent. If, however, that person happened to have been in your office, wasn't wearing a face covering, sneezed onto a staff person that wasn't wearing a face covering, now you may want to treat it very differently. Which is why I think a lot of practices are adopting face coverings for their staff, which here in Illinois, we're required to do by our governor's mandate, just to prevent those kinds of things from happening. Because if my, no face covering direct contact happened, then you may want to send the staff person home to quarantine. Other than that, they're probably just going to self-monitor, as they would be doing anyway, meaning they're checking their temperatures, they're letting their supervisors know if they don't feel well, and if one of your staff gets sick, you're sending them home and telling them to go see their doctors.
That sounds like there's a big range in there. Jovana, we have a question that asks about where, when, and how to test patients. So I have heard of clinics that are using PCR tests for every patient.
Right.
I can't imagine that everyone is doing that, but which test do you use? Do you PCR test? Do you use an antibody test? Or and where, when, and how do you decide which patients to test?
So we actually haven't been using any testing so far until we see. We're probably going to be going for the saliva nucleic acid rapid test once the validity of the test has been proven, because again, as Lisa mentioned earlier, having references, having the reasons why you do certain things have to be documented in your SOPs and your plans. So far, on one hand, we have tests that had not been validated that can be done elsewhere. We haven't been testing our patients. We've been screening them, obviously, with questionnaires the day before they're coming in, as well as the day off coming to the office. All the patients have to be wearing protection, and their temperature is being checked upon the entry into the floor or into our office. We will probably be going for testing, and what a lot of, or some of the practices are starting to do is what I hear from my colleagues and my friends who are at other practices, is that potentially starting to do a rapid test, either ELISA or the rapid test at the beginning of the cycle. The question is, okay, you've done it at the beginning of a cycle. Do you then have to do it every day? What if they got, when on the way back home, they took an Uber, or they went to buy a bottle of wine and got infected from, a guy in a liquor store? Do you have to test them daily then? If you have tested them for the viral presence, you did a PCR, and, even testing patients for antibodies, doesn't seem to be that helpful, because they might have an immunity that might be gone in a week or a month or 3 months or a year. So this is why we're actually not tapping into testing as of yet. We're still relying on screening and social distancing in our offices, and protection, obviously, and protective equipment. But those are some of the things that we're considering and we're discussing as a group.
So I'm going to launch a poll question, and I'm curious if I start to see responses come in, then I'll know that people are seeing it. And if people are not seeing, I'm starting to see responses come in. So the question is, are you testing new patients for COVID-19? Yes, we're testing all patients. Yes, we're testing select patients only. Or no, we're not. I've got 15 responses in so far, and I'll give it another 15 seconds or so as we start to get more patients or more responses in. The question is, are you testing new patients for COVID-19? Yes, we're testing all of them. Yes, we're testing some select patients. Or no, we're not testing new patients for COVID-19. Because I venture that as much as whoever asked that question wanted to know the when, where, and how, often the underlying is, what is everyone else doing? And so we'll have somewhat of an answer for you very shortly from our 21 person sample size, or 22 person sample size. I'll give, we do still have a few more coming in. So if you want to answer that question, and we can't see who is answering at an individual level, just the aggregate. I'm going to end the polling now and share the results with you. So the majority of practices are not testing for COVID-19, although we do have a few that are testing every patient, which is interesting. Lisa, did you want to add anything to that?
No, I don't think so. I mean, I agree with Jovana. I think that it's still kind of all over the board as to what is the usefulness of the test itself. I know some practices in the Midwest are testing at the start of ovulation induction to at least give themselves some sense of security that they made an attempt to find out who may be actively shedding the virus or not. But as Jovana said, how does that help you 10 days from now? It really
one thing that, I'm sorry to interrupt you, Lisa, but
that's okay.
Just wanted to, the only situation that comes into mind as to where or why would this be helpful would be really to identify those who have the antibodies, who could be donating plasma for convalescent plasma, which has been being done at Sinai and being used to treat the most severely ill patients. But I mean, I don't know what your thoughts are, but I really don't see, that's exactly right. I don't see the usefulness of it.
Dr. Adamson brings up a point about the usefulness in one particular circumstances, because there are so many unknowns about the virus and the antibody test. They can't be relied upon, except in that a positive test for virus could be used to cancel medical procedures and quarantine the individual.
Sure.
Correct. And I think most, providers that had somebody with a positive test or positive symptoms they're going to cancel treatment and they're going to quarantine. So, or suggest the patient quarantine. We can't just put our patients in quarantine all by ourselves.
Right.
We have a question about alternating teams, and I want to know if you've seen this, Lisa. When this was all first starting to happen, so this is pre-ASRM guidelines, which I think for the first time, guidance, which first came out on the 27th of March. This was pre that, and I was speaking to one physician who said that they had split their teams. They have A teams and B teams, clinic, lab, and office. A team comes in at 5:30 or 6 in the morning, whatever it is. They stay till noon, and there's a 15-minute gap where they leave, get in their cars and go, while team B is in their parking lots, comes in 15 minutes later after the entire office has been sprayed and disinfected, and they never interact with one another. The nursing team A is always on team A, team B is always on team B. Have you seen this, and how is it working?
I actually have talked to a couple centers that are doing it, and they're doing it essentially to try and conserve resources in case they get an outbreak among their staff, so that they can also tell who had contact with whom, and they can, so if a person on team A is positive and they know what the contact was on that team, they can isolate more effectively than they would have been able to do otherwise. I've also seen teams used as one team is on for a week and then they work at home for a week, and they're doing it that way, back and forth. My understanding is this is what's happening in some of the ERs. I have, and really proud of my niece who just graduated nursing school working in an ER in Milwaukee, and that's what they've done, is they've divided into teams, and it's a way to make sure that they can help protect their staff as much as possible. So in the Midwest, we haven't really gotten up to full speed again. How that's going to work, over time, you're stretching your resources. And for all the small practices out there, I have no idea how they would be able to do that, because you just don't have enough staff to be able to cut them in half. Makes it hard.
Jovana, what about at RMA? Are you all splitting into A team and B team? How is workflow being divided?
That's exactly how we've been practicing at every level, really, up until really 2 days ago when we slowly started opening up. But pretty much anybody who doesn't need to be there in person, which would be IVF coordinators, finance advisors, some of the nursing staff, people are just working from home. And then physicians, nurses, as well as the embryologist is the most important part and most vital part of our team, have been working in teams, so that you're always within a certain team, exactly for the reason that Lisa mentioned, which is, if one of the team members would get sick or would develop symptoms, and the teams would be separated into days, and some of them into hours of the day, but mostly into one day is one team, team A, and then team B. You will be able to easier track the contacts of that person and to monitor for symptoms, or to then do the testing of the other ones, and thus keeping the workflow and keeping, being able to have more hands on the deck. And again, this is one of the policies or interventions that we have implemented and then we have adopted from Mount Sinai, because this is how our physicians have been, our OBGYN physicians have been working on labor and delivery floor. Pretty much all of our fellows got redeployed, so we're obviously monitoring that as well. And our fellows have been working in different teams on labor and delivery as well as in the emergency room. So I think it's a good strategy. I don't know, Lisa, what you think, but I think it's a smart strategy when you're dealing with such a contagious predictably contagious disease that spreads so easily, and that and you still have to get the job done.
No, I absolutely agree. I think, if you can make it work, it certainly makes sense. You would hate to have your entire embryology team exposed.
Right.
And how could you move forward? Nurses can't do that. You can, as you said, redeploy people to do a lot of different things, but there are certain positions
Right.
that you just can't fill and you can't learn that quickly. So if you can do it, I think it's a great strategy.
I'm curious about asking this to the group as well. So I'm going to launch a poll question to see what folks are doing. Are you dividing your staffs into teams that do not work at the same time? Yes or no? Poll questions are starting to come in. Ooh, it's a 2-horse race, folks.
Uh-oh.
We have about 20, almost 20 responses right now. So I'll leave this for a few more seconds. Is more coming. Ooh, it is neck and neck. Who's going to break the tie? We're definitely seeing a pretty close variance here. So I'll leave just a few more seconds for those folks that want to answer. Are you dividing your staffs into teams that do not work at the same time? And I'll share the results now. So it was pretty close. We're seeing about just about half and half for those folks that say that their staffs are divided into teams that don't work at the same time. So it seems like it might be a good idea, but I also know that there are people in this call who run their practices with 7 people. So for some folks, it's just not going to be tenable. Dr. Retzloff says they're splitting the lab, but not the clinic. Which is a good point. So some folks are doing it for part. One of our questions, and ladies, you may have seen this. I'm not sure exactly what they're asking when they say how to homogenize the input in IVF to have a stable activity without peak. What I'm guessing is their backlog of cycles that didn't happen in March and April. I'm taking it to mean of how do they distribute that, especially if these are cycles that were already paid for, without maybe just having 2 weeks where everyone is just burned out working every hour they can. How do they distribute that better? Do you infer the question differently? And if not, how would you answer it?
Lisa, would you want to?
I was a little unsure, so I appreciate the explanation that you just gave, Griffin.
I might be faking the funk, Lisa.
Yeah, there you go. But we'll make it fit what we can answer. I am hearing from practices that they have kind of divided their patients into who they consider more urgent than others. Some are doing is who was more ready, who could, where their cycle was falling if they didn't keep them on birth control or something else. That's how they're getting them in. Everybody is pacing though, again, because you don't want to have this huge onslaught at the same time we do have to take into consideration that many geographic areas have not hit their peaks from what we are being told with the infection rate, and that some, as they start to open up and go back to work, we are going to see another increase in the virus. So both of those are going to impact the availability of your staff and maybe how the patients are going to be able to move through. So those are the 2 ways I've seen it does. Some are more urgent than others, perhaps based on age, AMH, what other parameters, and some are more prepared to move forward. Jovana, what are you seeing in your center?
That's, thank you, Lisa. That's exactly what we've been trying to do as we're, obviously when the first SRM guidance came through and, mid-March, we just stopped all treatments. We still had to take care of a couple hundreds of patients that were actively in treatment in the middle of IVF. You can't just leave them unretrieved with, dilated ovaries. Having an ovarian torsion gives a much higher risk of ending up in the ER at the time of COVID and diverting resources from COVID patients. So there were also pregnancies that had been conceived before the first guidance came out. So we had to sort of obviously wrap those up, treat those patients, see them through, stop all the actions. And so as we've been slowly starting to reopen, I remember that at that time, what was really important, because we had, shelter in place in New York State, and for those patients who really needed to still come for their treatments and complete their treatments that had been previously started, we have issued a letter to each patient that they are supposed to show to a police officer if they get stopped in the street, because that was the condition in New York in March and beginning of April. Now, as we're slowly starting to treat the patients, obviously, how you, and that's a very good point, Griffin, that it just shows a very good understanding of IVF process on your end, is that you control the number of patients you're going to have in the operating room or in the recovery room by the number of patients you're starting. Here or there, you might have, 22 retrievals as opposed to 17. I mean, we're a huge center, and so for us, that's not a big difference. But in this setting, where you cannot have as many patients in the recovery room because you have to have distancing. You cannot do and schedule procedures every 15 or 20 minutes because you have to ensure social distancing of partners in production rooms, of patients coming in and getting screened, of patients in the recovery room. We've been controlling, and that's really how you control it. I remember learning this from Cornell, really controlling how many starts do we have today. You need to know how many patients you're starting. So even if somebody ends up being triggered and retrieved a day earlier and somebody a day later, those are still not huge differences that you might see on a daily basis. So you basically have to see what your capacity is. Obviously, for each center, it might be different because not all of us have the same number of physicians, nursing staff that can help in the recovery room, not the same number of beds in recovery room, not the same number of, examination rooms, operative rooms, and a number of anesthesiologists. But that's exactly where you need to control that bottlenecking, is how many patients you're starting every day. And so for us, that has been a certain number that, depending on how many physicians we have, and, if we are able to continue working with the full capacity, it would have been maybe one patient from each physician every day, or one patient from each physician every other day to be able to start. If a slot goes unfilled, it can be, sort of filled by a different, somebody else's patient, or if there's a patient that needs to start more urgently. Speaking of those criteria, that is also very important. And so all of the physicians sort of prepare their own patients that will be going into the treatments as we're opening up slowly. And as Lisa mentioned, these criteria really are driven by, there's like a whole algorithm that we're using, but it's basically driven by their age, by their AMH, obviously cancer patients or patients who have a medical condition that might diminish their fertility and who have to be treated. Those are definitely more urgent patients. There are patients that we're not treating as of yet. And I'm sure, that might be a different question, but, patients who have a BMI that we used to, were able to manage that, knowing the high BMI is one of the significant risk factors for the most severe COVID-19 disease. Those patients might have to wait. Also patients with comorbidities, including asthma, hypertension. We're just becoming much more strict when it comes to those conditions, because if a patient is to get sick, especially if a patient is to get pregnant and then sick with those comorbidities, that patient is at a higher risk of getting sicker and needing a hospital treatment. And so there are definitely some, we put a lot of thought into this and a lot of criteria, and it's another SOP for us.
Connie wants to know if the clinic tests, who is responsible for their care if positive. So most of the folks answered that they're not testing, but there were a few that are. So let's say you get a positive, then who's responsible for their care? And then I asked, just because I think you could take that a few different ways, or you could have a few questions that offshoot from that. And said, if you cancel an IVF cycle, is it a sign off to PCP? What's the responsibility of the REI if they do test positive?
I think that is the same care that we would give to any patient where we found some other illness or condition, is you hand them off to another physician. So if somebody were to test positive for COVID-19 right now, most of the CDC, WHO guidelines, et cetera, say you have to have them contact their primary care physician, so that you're not just saying, we're canceling you and we don't treat this, because we don't treat it. We are not primary treaters of COVID-19. But, just if you were to find something else in your patient, if, we find diabetes,
Hepatitis
we
C.
don't, we don't take care of it. We send them to an endocrinologist. So I think, you need to just make sure that they get back to their primary care physician. Whether you want to do follow-up on that or not, it depends. Do you have a policy if you send somebody back to their physician for an illness that you always follow up? Then my recommendation is always follow your policies. Don't make this an exception.
Lisa, in the beginning when this was happening, there were people that, this was pre-ASRM guidance back in the early days of mid-March when people were
Seems
just,
like years ago.
it does,
Yeah, it was years ago, I think.
not kidding, it really does feel that way.
Yeah.
I feel like it's finally gotten back to week, whereas at that time it was hour to hour how rapidly everything was changing. And one of the things that people were starting to offer or to consider was just to say, if you have to cancel your cycle, that it will be refunded by the practice. And then some of the pharmacies and the manufacturers added on to that if you test positive during a cycle, will refund your medication, or will at least allow you to reorder with a credit of the same value when you restart.
Mm-hmm.
Is that required, Lisa? Are most people doing that now? What can you advise with respect to refunds and restarts?
I have not seen anything that says it's required. Okay. Meaning that if a patient has paid you for services that you've provided and they get sick with the novel coronavirus, that you have to give them their money back. Again, I go back to one, I think this is a time when people are being extremely generous, and I would never discourage that, because we want to make sure that our patients and our staff are healthy, and anything we can do to help them, I think is appropriate. But we have to let our patients know ahead of time. So as we're starting back, if our patients start treatment and we make a decision as an individual practice that if you make prepayments and we have to stop you, you will still owe us for the work we did, and it's spelled out up front and the patient's aware of it, that shouldn't be a problem, as long as you're transparent with your patients. But as far as anything that requires reimbursing them because they get sick with this, I have not seen anything at all. It's up to the individual practice.
Jovana, did RMA try this at any point?
I mean, fortunately, we haven't faced this situation as of yet. We certainly discussed it again as a group and discussed with our legal team. And precisely what Lisa said, I think that, what the consensus was among us was that if there's a work that was done, I think it's a case by case. Obviously, if we're treating a cancer patient, or if you're treating somebody who absolutely has no means or has no insurance, we're lucky to be, practicing in a mandated state. But that's exactly what Lisa said. All the patients are sort of being given this information booklet before starting. We discuss with them. Finance discusses their part, and they are fully aware and understand what the situation might be should they test positive. Obviously, their treatment has to be discontinued. At that point, when it gets discontinued, the RMA might not be able to reimburse them for their investments until that point, if certain things have already happened in the cycle, such as embryology, work has happened, or there was a retrieval, but we couldn't, do anything with the eggs or something like that. It's a very hard decision, and it is I just feel like it's, for all of us, I mean, these are such sad conversations to have because obviously, the unemployment rate has been raging and the whole world has been just financially going down, and economically it's a very, very hard situation. So more like less from a legal aspect of it, but more from a humane aspect of it, this is something that I think it needs to be also handled on a sort of individual basis. I think you have to take into consideration where the patient's coming from, what is their situation. I mean, we've donated cycles many times before, and for certain situations before COVID, before all of this. So it's an individual scenario that also counts, I think.
I'm only going to keep our panelists for another 10 minutes, and we do have a few more questions. I'm going to try to get to them, so we'll try to at least touch on them because we still probably have 3 or 4 more. Dr. Martin asks who's responsible if they test positive after they conceive. I imagine it's the same answer. You refer them to their PCP. Maybe he's asking if this is pre 7.5 week, pre 10 week, whenever they graduate from their REI, if they test positive and then some of their care is still scheduled. Maybe he's asking, do you see someone when they're still positive that if they need to come in for an ultrasound, they haven't moved on to their OB? What about a situation like that?
Lisa, did you want to?
No, Jovana, go ahead. I mean, I would think that you would have to look at how you can safely hand them off to somebody. Do you have to do that initial ultrasound, for example, to make sure that the fetus is where it should be, that you don't have an ectopic or anything like that? And perhaps, in the past when we've had infected patients, I've had practices that have used clean rooms in the hospitals to do those exams and not bring them into your practice. Something to consider. Have you even talked about that in your practice? That's a great question. Have you even talked about it in your practice?
I think it's a very good question, and we certainly have talked about it because, I mean, we monitor weekly. After 9 days after the transfer would be the first pregnancy test, then 48 hours later to ensure appropriate rise of the beta HCG, after which we follow with weekly ultrasounds. Are those weekly ultrasounds really clinically needed? Not really. And as Lisa mentioned, the one that's really there are 2 that are really essential for any obstetrical practice, or like early obstetrical practices we as REIs provide, which is you want to make sure it's in the right place, right? You don't want, you even in naturally conceived pregnancies, I always bring them in for 5-week ultrasound just to ensure it's not an ectopic pregnancy. Ectopic pregnancy is a surgical emergency that doesn't have to end as badly if you treat with methotrexate when you know that it's not in the right place. And sometimes the laboratory might not show it. Some ectopics have perfect rise, and then all of a sudden she has an ectopic. The other one is 7-week ultrasound that, we want to see if there's a heartbeat or so. So I think the crucial or the most difficult situation in this regard would be if you have a patient that is testing positive, yet you haven't identified an intrauterine pregnancy. All the other ultrasounds are actually not that essential, right? The patient's not in danger. If you documented intrauterine pregnancy, you might as well discharge her at 5 weeks, and she can wait for her obstetrician and make sure that, they wouldn't have, if it was a natural conception, they wouldn't have seen her, before 10 weeks anyway. And you can monitor progesterone, or you can just wean her off progesterone as you would usually do. The problem is this sort of micro scenario where you might have a patient who tests positive before documentation of an intrauterine pregnancy. And, I guess that also might go case by case, as you're saying. I think that's a very good idea, potentially sending them into urgent care. Obviously, you don't want to divert any resources from, providing care to COVID infected patients. But at the end of the day, it might be something to consider, to basically evaluate them at a different setting, somewhere where there's COVID raging already, which is an urgent care or a hospital, and basically just making sure that they have, or if they would have symptoms, let's say she starts bleeding or she starts having abdominal pain, then she would have to go.
We have a question from Debbie that asks, have clinics reduced their volumes or capacities to meet the IPAC requirements? I'm exposing my ignorance, the only IPAC that I know of is a treasury agency that allows agencies to pay each other. So I don't know what IPAC is. Have clinics reduced their volumes or capacity to meet IPAC requirements?
Lisa, no, I'm not familiar.
I'm not familiar with the term either, so if she could explain it, I'm happy to try and answer it.
It might be a Canadian Canadian regulatory body. So Debbie, if you can clarify that. We did have someone else from Canada asked a question beforehand, which is, do we think these measures apply outside the US in countries like Canada? My guess would be almost everything would. The variance of legal liability would certainly be different depending on jurisdiction, but it seems like most of what you've talked about applies in other countries. Can you offer some insight?
Well, what we're talking about is infection control and patient safety. I don't think that changes no matter where you're located. You're right, the legal liability may change based upon jurisdiction, but when you get right down to it, taking care of your patients, taking care of your staff, I would love to see that be the same no matter where you're sitting. So I think it applies everywhere.
Debbie clarified that IPAC is infection prevention and control. So have clinics reduced their volumes and capacity to meet requirements for infection prevention and control? I think by this point you both answered that
Yes.
quite a bit, that they certainly are.
Mhm.
So I want to thank you both for coming on. Is there any parting wisdom that you'd like to leave with as folks are continually revisiting their standard operating procedures of what they need to consider as they make and reformulate these?
I would just add that, even though it seems to have slowed down, we're still very fluid. There's still a lot we don't know. And that basic patient safety and infection control is what we're looking at. So keep that in the forefront, and on the back end of it, take good care of each other. I worry about acceleration of burnout. And as we're getting ready for Nurses Week, I want to say thank you to all the nurses and nurse extenders, and say, hang in there, everybody. And just keep working together and keep talking to each other. As Jovana said, I mean, that's the best thing we can do, is share information and help each other. So take care.
I mean, I couldn't agree more with what Lisa just said. I think these times are extremely important. It's extremely important to be kind to each other, because everybody's being hit. Maybe not to the same extent, but everybody's being hit, everybody's suffering right now, and we really need to be unified, not just as reproductive doctors or, reproductive, people within this field of medicine, but generally as humans, we just have to be really unified. I really enjoy, as I said, Griffin, I really enjoy reading, and I learned so much from your organization and from your podcast. But one thing that I keep reading in your interviews, especially the more recent ones, which is the hope of all of us, is that, well, what are we going to do when this is over, and when this is over, when this is behind us? And I just feel like, I don't want to sound pessimistic, but I'm not sure if this will be over, or if we're going to reach a certain low constant, and some of the elements of what and how we're practicing right now might remain for a longer time, and this might be our new normal. And so I think that, finding clever and inventive ways of handling these situations, I think it's a very positive thing. And I think that, as we said, stone by stone, sometimes you can't have everything figured out in a completely new viral pandemic that we haven't had in the past 800 years. But I think that being inventive, trying to think outside the box, because we might not have all the answers, and just getting used to this new normal.
That's a good closing note, Jovana. If we know anything from the Great Recession or from September 11th, some things go back to normal and some things never do. I thank you both so much for coming on Inside Reproductive Health. Dr. Lekovich, Jovana, Mrs. Rinehart, Lisa, thank you both so much for coming on the show and
Thank you,
educating our
Griffin,
audience.
for having me.
Thank you for having me. Have a
Thanks.
great
I'll see everyone next week at 4 p.m. on Tuesday. We'll be talking about the middle of the marketing funnel, of the patient acquisition funnel, the consideration phase, how we get patients off the fence and into the clinic. We'll see everyone next Tuesday at 4. And thank you both so much for coming on. Thank everyone else for attending.
Thank you. Have a good day, all.
Take care. Bye-bye.
Bye-bye.